Welcome everybody to the IHPI seminar today. I'm Sarah Hawley. I am the faculty lead for education and training, and we're very thrilled today to have Dr. Emily Martin with us. I'm going to introduce her and then we're going to let her just get going. Please go ahead and chat questions. I will be keeping an eye on those. We're going to let Dr. Martin kind of go through her presentation and then have time for questions and discussion at the end. So Dr. Martin is an associate professor of epidemiology at the School of Public Health, and she's an infectious disease epidemiologist with a focus on virus epidemiology and the use of vaccines and therapies to prevent and treat infection. Her research includes optimizing the use of diagnostics for viral diseases, and her current work includes studies of COVID-19 epidemiology and working with policymakers and community groups on strategies to reduce transmission. And I'm certain we're going to have a lot of discussion and questions for Dr. Martin. We've been really looking forward to having her give this presentation today. So with that, I will mute myself and I will turn it over to you, Emily. Thank you so much.
Thank you so much for having me. So I'm really excited to be here. I have not given this presentation yet. This is actually a presentation, as I put this together, this is something Marissa Eisenberg, who's my main partner in crime, and I have been wanting to put together for a long time. And it's this is going to be kind of year in review themed, which I'm sure there are many years in review coming about the last year in COVID in Michigan. But so hopefully this is on the earlier end of the years in review that you've seen in terms of what our experience has been. So with that in mind, let's see. There we go. I wanted to start with, so this is where we are now, and we're incredibly lucky to be where we are now, I think, in comparison to states around us. New York Times right now has our state appearing under where new cases are lower and staying low. They've got all the combinations of categories, high and getting lower, low and getting higher. And we oftentimes find ourselves in the lower and staying low category. But we have not always enjoyed the benefit of being the state where things were low. At the beginning, we were, the state of Michigan was really remarkable and identified for having such a high number of deaths so early in the pandemic compared to other states. And as this is it's a piece of data from the CDC's National Syndromic Surveillance Program, which is a great way, especially if you've got a situation where you have a real lack of testing or absence of testing, is you start using symptom-like illness. So COVID-like illness, this is originally developed to do influenza-like illness, monitoring for syndrome classes to look to see if things are moving in a particular direction. And what you see here is, despite having a really severe flu season and a really severe RSV season in February and in January, if you look specifically for the combination of symptoms most connected to COVID, you see that be fairly low in terms of percentage of emergency department visits until we start to see it start to spread around the country, and you have the first identification shown here in February. And I've put a circle here around when the first identification in Michigan would have become infected, around that area. And you see that here in Michigan, and particularly in Wayne County, we took off very quickly, and Cook County did also, but compared to kind of what was going on nationally, really in that early part of March. Now, my day job before I did additional day jobs that are COVID related was to help run the influenza vaccine effectiveness and surveillance systems out of the University of Michigan. We're one of a number of sites that partner with the CDC on monitoring flu vaccine effectiveness. And what we were seeing, and once we had the testing to do a look back to see what was going on in our network around this time, because remember, tests were really limited around this time period. We now know that in March 1st is where we think the onset of the earliest known case, based on the state health department data, was. The first clinical identification happened in Michigan around March 10th. And around the same time, we can look back into the flu networks and we can see cases start to pick up in that data as well. So we see this chatter all about the same time in early March of cases starting to appear. This doesn't mean that there was no COVID prior to March in Michigan. What it does mean is that, there's a difference between having chatter. We probably had viral chatter or independent introduction events that did not take off and turn into widespread transmission. But we're really confident that the widespread transmission really began in those first couple of weeks of March. And it's not just numbers. There are human faces to the experience in Michigan, particularly in the early days. I wanted to give just a quick recognition of this Detroit Free Press article that came out in December. It's actually accompanied by a very powerful video that they made with it. I had worked a little bit with some of the reporters as they were working on this story, but really talks about the early days of COVID-19 in Michigan. Both the toll and the burden, but then also, the kind of the impact of experiencing so much disease in the early days of a very new virus, where testing was uncertain and treatment was uncertain, and people were having a lot of trouble getting answers to the kinds of questions that they had on an individual level. So I really recommend this story. So things started to happen quickly in Michigan after cases started to appear. This is a graph from covidmapping.org, which is a website that's a kind of a spatial tracking website that's maintained by John Zellner's group at the School of Public Health. But by March 13th, K through 12 schools were closed. By March 16th, bars and restaurants were closed to dine in, gyms closed, coffee shops closed, most public places were closed. By March 18th, the big three automakers announced that they were going to begin shutting down as a workplace. This was a really big, I think, sea change in terms of how employers started to think about exposure. And by March 23rd, we had a statewide stay-at-home order. So this is kind of where I'm going to begin my story. I'm going to talk about starting from this perspective of we have this statewide stay-at-home order. How do we get back out? How do we move out of this in a way that's safe and measured and data informed? What were we going through as a state, and what were other states going through as well? So the two major questions that were happening in April were, when will the peak be? Every reporter, every Twitter feed, everybody was talking about when is it going to peak in Michigan. This top graph I have on the right here for you, this is deaths over time for the state of Michigan, and on the bottom is cases over time for the state of Michigan. And what I want to point out here is, there was real hesitation on the part of a lot of epidemiologists around the question, what if this isn't the peak? For deaths, this certainly was the peak. Of those early days, and we had a second peak of deaths later. But if you look at the cases in the bottom and you look at where April is, I mean, that it almost looks like a blip compared to the caseload that we're seeing later now. Now, of course, testing has changed what we can see, but this still kind of brings up the fact that our perspective on these questions of the virus peaking or different caseloads has totally it's changed and shifted throughout the course of the year. And the reason why everybody wanted to know when the peak was is because everybody wanted to pre-predict, when do we know when is going to be the right time to open up, and how are we going to know that it's time? And ideally, what policymakers wanted to know is they wanted to know how to tell that it's going to be time to open up and re-engage in 1 month, because you can't turn on the lights just with a switch, right? There needs to be lots of preparation and other things that need to be done to get businesses back and rolling again. And so it was really, can you predict when things are going to be low enough for it to be quote unquote fine? And by the way, what does that mean? What is low enough to be fine? What number is required for that to go forward? So it was, a lot of the conversations had this tone of, well, are we there yet? When will we get there? Now I put a train on the bottom because at the time it became very clear that a lot in our state and a lot of states and the national government, there was a visualization of this process as a one-way track, that we were as bad as it's going to get. how do we pace and understand how quickly we're getting to the end, but we know we felt that we knew we were getting to the end by the summer. And that's kind of created a lot of complications that I'm going to talk about how we measure and how we track the epidemic. So around April, this is when the team at School of Public Health got really involved in trying to think about indicators, this idea of how will we know where we're going and when we get there, and what kind of indicators do we want to use? And so really trying to identify measurable indicators, what kind of statistics should we be monitoring? How are we going to monitor these on a real-time basis? We were really couching our thinking around measuring epidemic spread, healthcare capacity, and public health capacity. So if you can have a lot of spread, these don't always travel in the same direction at the same time. You can have a lot of spread that's not necessarily impacting your healthcare or your public health systems as badly. Possibly you could have not a lot of spread, but in a particular population with a high risk of severity, so you are having huge healthcare and public health impacts. And so these all sort of needed to be measured independently, and they all need to independently inform decision making. So we started to build this framework of what kind of indicators we would use to measure the pandemic in Michigan. A lot of focus was around using current systems wherever possible. Not a lot of time or money to build totally new systems, but there was time to build tools that can integrate with the systems that were already in place in Michigan. And then thinking about this from this multiple facet idea that you're going to have to measure multiple streams of information at the same time, with the ultimate goal of having a dashboard that can allow us to visualize and integrate all of this information. So as we started to think about, these are the kinds of numbers I'm sure a lot of places you may have heard in a lot of other places. I have to say, I was not expecting like a major American media fad of talking about percent positivity, like deep dive explainers on percent positivity. That caught me off guard. In the flu world, we've used percent positivity for a long time to kind of mark the beginning of a flu season. And suddenly there were like these very with flashy pictures, like articles in the Atlantic and stuff about what percent positivity means. It was an experience. So we were looking at both, especially focusing, and today I'm going to talk mostly about the epidemic spread indicators, talking about, case levels, percent positivity, but then also talking about the importance of monitoring for symptoms. When you have a scenario like we did in the beginning, where you've got very low diagnostic capability, symptom monitoring becomes very, very important. This again, but remember this is April. So this is before we really understood the impact of asymptomatic transmission. And so I think at the time, we really put a lot more stock in symptom screening than, as that being able to potentially take care of a lot of the outbreak control. When it turns out the asymptomatic spread turned out to be a lot more important, we found out later in the summer. I do have to say though that symptom screening to this day, and I'll talk a little bit more about it as we get further down, it still is a really important thing. Like even though not all COVID-19 cases are symptomatic, we still don't want symptomatic people wandering through our workplaces and our schools right now. So we were, our goal was to try to get to a place where we could define what the numbers would be on the ground to let us know that epidemic indicators have stabilized, have reduced, and that healthcare system capacity was sufficient. These are situations that are pretty easy to broadly describe and really hard to put numbers down. Like how many cases is enough cases to know that we're at that point where epidemic indicators stabilize. Sharon Cardia was a big leading force in this effort. And I remember as this first started to get put together, I said, I'm going to make these broad strokes, but I refuse to set a number because this is so complex. It is so hard to pick a number. And you're going to see as I go through this presentation how Sharon Cardia made me pick a number. The indicators, as we were monitoring them, we're going to, again, you can see the reflection here of thinking about risk phases, but this is very much driving toward, again, this idea of the one-way track. That in April, in March and April, we were in an urgent situation and we wanted to know when we're going to get to something that's more stable, and then when we're going to get to a recovery where everything is decreasing and continuing to decrease. One of the really early messages that was really hard to deliver to policymakers, but then once it started to take off, it really started to work well. And we harped on this a lot, was if you look at just the time between infection and infectivity, the incubation period of the virus. And this is something that's very unique to SARS-CoV-2, very frustrating about SARS-CoV-2, is that long incubation period means that we were often having to wait for 2 weeks of data to understand if we had made the right or wrong decision about anything. So you'd have to open a little bit, wait 2 weeks for an answer, and then again. Or if you have a big exposure event like a holiday or something with a lot of travel or a lot of social activity, oftentimes you wouldn't see the impact of that activity until 2 weeks later. And so it means that these decisions about how you change policy are very, very slow decisions throughout the pandemic. And I think for policymakers, that's been an incredibly frustrating thing. On the flip side, this is one of the messages that I think has become really pervasive and successfully got out there to a lot of different places. So even in the White House plan that was released in the summer, we would see shadows of, okay, make a change, but you have to wait for 2 weeks before you can make another change. This idea of progress, pause, progress, pause was being kind of shown in a lot of different plans. Around this time, and one of the reasons why we were really advocating for this slow progression of relaxing of restrictions was, Marissa Eisenberg's group, the modeling group, had done some simulations about this time for the state of Michigan as well, to think about how many cases can be averted by a slow ramp up versus a fast ramp up. And these different scenarios sort of show on the left-hand side on this graph, it goes from basically 0 to 100, how much 0% to 100%, how fast are we getting back to our quote unquote normal activity? The faster that you go, which would be like the light blue curve on the left, the more likely you are to prompt a boost back up and a peak back up. But the slower that you go, the more you're able to kind of mediate the return of transmission in a way that stays kind of at a more reasonable level. And we looked at, one of the interesting things is a lot of the work that we did over the spring and the summer was to start to break what was happening in Michigan into very regional level patterns. And so, because throughout the spring and the summer was very hotspot regional level things that would happen where the outbreak would get huge in one community and nothing in a community that was like a half-hour drive away. And so this had implications for the potential if you open out of restrictions too quick in terms of what kind of epidemic they could be looking at depending on the speed of the ramp down. So actually, Marissa got to present her models at a press conference. And so I wanted to put up a picture of her doing this. Fun fact, I'm off screen, like in the back corner, because I had to drive Marissa because she's actually like 8 months pregnant in this picture. So like I'm always forever impressed by the fact that she did all this. There's this need, we know that there's this need to kind of pace the reopening. And in order to do that, you have to do it by figuring out what your metrics are. And this is where I sort of started to lose I was no longer able to dig into my refusal to put numbers to things. And we started to characterize, how are we going to take these pieces of data we're measuring about the state and collapse them in a way that we can use them to make decisions. So we started thinking about things like, is the overall amount of disease in a community low enough? Are we seeing consistent decreases in cases? And is our percent positivity low enough that we know that we're capturing enough of the epidemic that we can trust our information? But it became clear very early on that this is a complex enough situation that numbers alone can't make the decision for you. You can't have a computer or a robot decide if a region is ready to have more kind of contact and interaction. And so you always have to have this epidemiologic context and framing that is always paired with that other information. Along with that context and framing is, in the lower right-hand corner of this framework I'm presenting, is that public health, local public health, always needs to have the ability to throw the penalty flag on the field and say, I don't really care what your number is. Things are moving too fast and we can't keep up. There are too many cases for whatever reason. Maybe there's a staffing shortage. Maybe the dynamics of the epidemic have changed in a way that is concerning. They need a way to have a voice to say that, things are challenged from a public health capacity side. As I get into talking about what happened in October, November, and December, you're going to see some of that pattern emerge for sure. So, taking some of these pieces together, I'm flipping through a lot of these draft strategies we use for how do we measure and how do we think about how to use data in real time in a pandemic like this. So an example would be, we're in an urgent situation, but over a 2-week time period, if we can say that, a region's disease trends are improving, if the epidemic indicators are improving, we can check with the health department, they're okay, check with the medical system, they're okay. You can move to the next level, open up more services, and then you wait for 2 weeks. And then you can go through the whole process again and move to the next level. Some states operationalize this interestingly. On the West Coast, there were some states that did this by the local health department would be in charge of doing this monitoring. And then they would submit like an application to the state health department that would say, here are our numbers, what do you think? What we really wanted to try to work towards is trying to get to a place where we've got this real time, all of the information needed to have this conversation is available to everybody on the state, decision makers, but local health departments, but also your average person on a regular basis so that they can watch these different numbers move. This was the first I did this in PowerPoint with tables and making colors and things like that. The first very basic attempt that we made of trying to put this into a picture. Both this need to be looking at different regions separately, but then to be looking at different risk phases. And it almost it kind of reminds me of a Yahtzee card where it's okay, have I done this? Check. Have I done this? Check. Have I done this? No, we need to wait and see if we can do this next week. But sort of this checklist of benchmarks you would need to meet to be able to move to a lower risk level. Again, this, this 2-week pause was kind of critical to this thinking that you have to continue to go slow. You have to continue to monitor for rebounds. And we were constantly advocating for this, you have to wait out at least 1 to 2 incubation periods before you can see the impacts of whatever stage you're moving out of. And one of the things that we were concerned about particularly at the beginning of the summer, because of the hotspot patterns, we were watching for sudden outbreaks and potential increases in transmission, and that would kind of work against our assumption that we were on a one-way track to improvement. And this was, for instance, we're always watching the high density regions, high density settings, but we were also keeping a really close eye on regions that had not yet seen widespread community transmission. So there were still in early summer, a lot of regions in the state that had not had a rise in transmission. So completely, if we sort of think about fuel for a forest fire, there's completely dry wood on the ground, a lot of potential for an outbreak to really take off. Around this time, we were also really trying to build resources to get workplace level infection data or symptom screening data. And beginning to introduce this idea that if things get back out of control again, if there are a rebound, we might have to reconsider kind of the pace or the specific policies for re-engagement. So, so a lot of those pieces were kind of being circulated late April, early May, and May is when the state came out with their official My Safe Start plan, which was the policy plan to kind of move things forward. There were a couple of things in this plan that I was particularly glad to see. One was, the stage. So the stages on the left sort of looked a bit like there are shadows in here of some of the stuff that we had in those various boxes that we were putting together. Plus this arrow idea of like, you've got to do something to get out of one stage into the next one, into the other stage to the next one. One of the things though that was challenging about this plan is it's numbered, the phases are numbered 1 through 6. And there was a lot of thought put into progressing from 1 to 6, but not as much thought other than that tiny blue line, the arrow going left on the bottom and the left-hand side of the slide. There wasn't as much thought about what would happen if you had to go from 5 to 4 or from 4 to 3 or from 3 to 2. I think we were, there was a lot of optimism that we're going to continue to move forward. On the right-hand side of the slide, you can see the indicators from the public health framework that we made at U of M are reflected here in terms of new cases per million, monitoring the trends overall, and monitoring the percent positivity. And this is a kind of an early draft of when we first started to figure out what, if you take all of these categories in terms of if you wanted to couch where we are as a state, what does persistent spread mean? What do those numbers actually mean? What do the thresholds actually mean? What kind of public health capacity would we like to see if we were in a flattening environment versus an improving environment? And these are very kind of soft concepts, and it gets really challenging to actually put a number on a concept like that, but we needed to start to make these various thresholds. It was also, at this time, it was also really fascinating to watch other states struggle with the same challenges. So I had a really exciting weekend where I read all 50 states' COVID plans. And I started making all of these grids and charts to figure out how was everybody else dealing with this question of, how many cases are too many cases? At the time, only 5 states had official state presented published thresholds for how many cases they found kind of quote unquote unacceptable. What we saw were more states using kind of looking for a decreasing trend to try to open up or engage. Some states were using syndromic surveillance. A lot of states were using these various percent positivity thresholds in terms of where their warning line was for engagement in economic activity. There was only one state, Kansas, that was using death trends as their primary indicator for decision making at the state level. And I'm going to talk about this, but death trends are very hard to use for decision making because they reflect information that's probably 6 weeks old. So the state-by-state comparisons also, we even did this as far as looking at low, medium, what did low, medium, and high look at in different states in terms of their percent positivities. I had graphed a whole bunch of what did every state that had a percent positivity threshold, what was that threshold? We also were seeing a whole lot of independent agencies, COVID exit strategy or independent groups, COVID exit strategy, Resolve to Save Lives, COVID Act Now, Harvard Path to Zero. A lot of people were weighing in on this question of how many infections are too many infections, or what percent positivity is just simply too high. And so you see a lot of variation and everybody kind of struggling with the same general thing. Illinois, it was interesting, Illinois like totally changed at one point from 20 to 8, and they just kind of moved it. And this, our kind of gathering of all of these and finally settling on a set of numbers for each of these indicators that we were happy with, that's what became what we call the framework. My colleagues call this the document of doom, because at one point this was like this 30-page document, and anytime a legislator or community organization sent me a question that was like, what % positivity you think should be the right one to do X? It would send them this 30-page Word document. It eventually became something that's much formatted and nicer and easier to read and more accessible here. So what the framework eventually became, I mean, this is all well and good to spend a lot of time thinking about how do you measure things. You got to actually measure things and provide that information to the community. And what we were able to do through this incredible partnership with the School of Information on campus was make the COVID-19 dashboard, or my START map. And it's by startmap.info. It's my all-time favorite website. And what this website does is it does both county and regional level tracking every day of cases, deaths, % positivity, all of those indicators that I was talking about. It tracks them and presents them in a really accessible format. But the other thing, I mean, this time I got to go to a press conference. Marissa had her baby and she was busy with the baby. So here is what my START map looks like now. You've noticed the colors have evolved. We got to a point in the epidemic as it got bigger and bigger that we needed more colors because we ran out of red. Red was going for a very long time. We needed more colors. So we switched to this kind of scales of purple, scales of blue and purple. It's had mixed reviews. I like it. So we now are able to distill down those various indicators that we use and assign a risk level from low to A to E that kind of talks about the general risk of transmission and kind of overall pandemic risk in a county. The risk level is largely based on the epidemiologic indicators. And you could look at it at all sorts of levels, all the way down to the county level to see how things are going. We give test results, cases, symptom data, death data, healthcare capacity data, testing capacity data, all sorts of things that both decision makers, but then smaller groups that might not have, a really strong link with their local public health department, the ability to kind of see what's going on. We always try to accompany things with narratives. A lot of times it's really important to try to put these numbers in context for people because there's some on the ground truths that are needed. I have and sort of what our goal is on an individual level and in informing communities is that you can go to this like you'd go to a weather map and say, where is my county today? I want to travel to this place, or my business has business in this other place and I want to see how they're doing, to be able to easily check and kind of compare the risk of in different areas around the state. I over the summer I was talking with a former college roommate of mine, and she was like, hey, have you seen this great website? I check it in them every morning before I check the weather. And sure enough, it was my START map that she put up. And I can say, oh yeah, I helped make that. One of the big features I think that we're proudest of is this, the compare page. So it's a link on that dashboard that lists all of the analytics by county and by region for all of these different metrics that I've talked about. One of the ways that this has become very useful is that both the court system and now individual school districts need to understand their county risk level to be able to understand how they fit in with various state and federal policies about how to engage. And this gives them this like one-stop shop to be able to see every piece of information. I talked a bit about the importance of measuring case trend. And one of the big challenges is actually really hard to measure the trend of something that has a weekly sawtooth cadence. So because you always have cases always go on down on the weekend just because of patterns, just because of testing behavior. And so we've experimented with a lot of different trend algorithms over the last year. CDC has one that we're currently using. So as I mentioned, that death information gives you pretty old information. If you are following deaths to make decisions, then your information is talking about infection events that happened potentially 6 weeks earlier. Hospitalizations can be laggy. Even positive COVID tests are giving you 2 to 5 day lags in your information. But with symptom tracking, you have much more real-time information. You remember at the beginning, I sort of talked about COVID-like symptoms as being a tracking mechanism. And with this in mind, and kind of with an understanding of the various requirements about symptom screening for the workplace, we had introduced these My Symptoms app, which is kind of a free tool that we were able to make available to employers and community groups, school groups all across the state that wanted to do symptom screening. This is something where, so College of Engineering was incredible in pulling this off. And this information actually then gets processed in real time, posted to the dashboard as well, but then provided to various decision makers. This is a space where we had a lot of people kind of offering very expensive licenses for private products that companies were producing. So being able to provide something that small businesses could use right out of the box was pretty incredible. So again, this will serve, we've got a lot of more work going in this direction, but we're continuing to build this out so we can start doing things like hotspot mapping. Hopefully we're going to get to an eventuality where enough people are vaccinated that we're really watching for outbreaks to emerge instead of having widespread community transmission. And so having real-time symptom tracking data like My Symptom app provides is going to be really powerful for these. So the last thing I wanted to kind of talk about is sort of where the last few months have taken us. So we've got we've got in June, we've got some interesting kind of patterns. It was very much slowing down. It wasn't slowing down as fast as people wanted it, but it was definitely slowing. But bring it to current, and we were all like, okay, these last couple, if you can see the lines of where I was setting the metrics and daily cases per million population, we're like, oh, just a couple more lines and we're down there. We've done it. The train has completed its track. But then you take this further and you see where we are now compared to June. Cases have exploded compared to where we were. If you look at the death graph, the death peak over the fall kind of matched the death peak in the spring for Michigan. But the cases really exploded. So what happened as we realized in the summer that we actually weren't bringing it down to zero and we were trying to figure out what was going to happen next? One of the things that we noticed, and you can see this in the map data from the New York Times, is that behavior was very pocketed in different places. So really varied levels of compliance. So the dark areas here are with really high 100% masking compliance, and then the light areas where we're not. In the summer, it was really, it was some of the areas that got hit the hardest in the beginning, had the highest uptake for the different policies and regulations that were getting put into place. What we saw as we moved into October was that really starting to see, an uptick of another trajectory in terms of cases. And what was really concerning in October, there was actually an MDHHS COVID roundtable to brief policymakers, various decision makers. And one of the things that we tried to emphasize around this time, around the roundtable time, was the fact that, unlike in the spring, the increases were everywhere. So now we were approaching the situation like we're in now, where every community is struggling with COVID, not just some communities at a time. This is really now a statewide thing that's being seen. In the fall, we were also seeing a real age shift to the epidemic. Way more younger people were being infected than earlier in the pandemic. And what that meant was, a real change, and it has to be a change in strategy, because even though hospitals weren't getting hit as hard because of the young people, public health was getting hit incredibly hard. And so what you see in those types of scenarios where, I'm going to go back when you have an age shift like this, you're having an increase in infections in an age group where the average number of contacts per case can be 10 or 20 in a county instead of 3. So the amount of work to contain the epidemic had completely changed in what it took in order to respond, and public health was getting completely overwhelmed. So where in the spring, the response was more about healthcare capacity and taking care of healthcare. In the fall, the response was more about what do we have to do so that public health can do the work that they need to do to continue to contain continued spread. And this is where the pause to save lives that happened around the holiday season happened. And if you see, a lot of these recommendations are around reducing contact networks. And so there was, again, restaurants and bars, there's pauses on in-person learning, but then also reductions in gathering sizes, and a lot of communication around how do you keep the contact number down, which means how do you reduce the number of gatherings that are happening. The kind of temporary nature of this, of the pause to save lives, one of the reasons it was a pause is one of the, is kind of around this idea, we call it a circuit breaker, where this idea that it's as we move into the next couple phases of the epidemic, we're really going to be wanting to have these moments where we pump the brakes for individual periods of time, right? Rather than having long-standing policies, it's like adapt, pump the brakes, get the rate down, do a reopen, and then see where it goes. If you run into a problem, do another. And so this is a modeling effort by a group at by Mark Lipsich's group at Harvard, where you can see these blue things are sort of modeled instances where you pump the brakes, do a pause, then reopen to try to kind of oscillate the pandemic within a range that you can really deal with. So there's, I'm going to leave this here, kind of wrap up here. We have a lot of things on the School of Public Health website about social distancing, or about social distancing related to pause to save lives, and the various case reductions we think are probably linked with that. And then from there, I just wanted to mention we've got plans going forward about other tools that we're going to build. So building really granular mapping tools for local public health is in process. Adding much more of a disparities focus to everything that's being done, including the dashboards. And then this is something I'm proudest of, is that, just from the number of users we have and the number of hits we have, that we see that a lot of people are using these tools on a regular basis. And I love the average session duration is about a minute. You log on in the morning, you look at it, you go like, okay, I think this is where we are. And then you move on with your day. And that's one of our big goals. So I will stop there.
Thank you so much, Emily. I expect that people may have interest in seeing some of the slides again. I'm not sure, but folks, please feel free to jump in with questions. There was one question that came through earlier from Jim Bagian. I'll just read it out. Will you discuss the rationale behind using percent positivity and the confounding factors impacting the accuracy and precision of this measure?
Yeah, so percent positivity is in a stable testing system, like when we use it for influenza, it can roughly benchmark spread and infection rates. But what we have with COVID is an unstable testing system. And so what percent positivity ends up doing for you is it really shows you how much of the margins of the outbreak you are successfully identifying. So it becomes then a public health metric instead of a spread metric. It's kind of both. It kind of encompasses both. It's like, how good is your system doing at detecting, and how fast is the virus moving? And so using it as a standalone metric is very, very difficult to interpret. And it's really easy to manipulate. I've seen this happen. I've seen, not locally, but I've definitely heard of instances where a group will be like, well, we need the percent positivity in our county to be under this number to do what we want to do. We're going to test 20,000 more people, right?
Great. Susan Gould has a question. Susan, can you unmute? Do you want to ask your question? It might be, if you can, otherwise I'll ask it for you.
Okay, it took me a
Yeah.
minute.
Yeah, go ahead.
Okay. Yeah, I'm just curious, Emily, by the way, that was a fabulous presentation and thanks for coming or sitting or whatever to do it. Yeah, yeah.
Joining.
The work from home thing. Can you say more about the plans? I have to say I've been a bit disappointed that when you look at like the Kaiser Family Foundation information about states and vaccinations and disparities, Michigan doesn't have racial and ethnic data available in that, and they're now that now there are less than 20 states that Kaiser hasn't been able to get that information. So can you say more about what the plans are? I realize that with vaccination providers being required to collect racial and ethnic data doesn't mean the data is going to be any good. But can you say more about what the plans are to be able to look at vaccination and disparities, whether that's using zip code or census tract or racial and ethnic data, and when that's going to start and potentially be available?
Yeah, I can say from my understanding of the data, missing data in Michigan is entirely differential by race. And that's what makes it so difficult is we know that we're not measuring, and that in itself is a disparity, right? That there are communities that we don't have enough of a view into what is going on if we're using kind of our standard public health data systems.
And when you say there's missing data differentially by racial and ethnic group, what you mean is data collected by vaccine providers or?
Yeah.
Okay.
Yeah. Yep. So the dashboard, we actually have a disparities view that's modeled after, it's kind of, it's really based on what they did at COVID tracker for their disparities view, a COVID race tracker. That's going to be coming out in the next couple of weeks where we can see which counties have disparities evident in kind of their testing and case data in this like nice visual scale type of way. And so that's going to be coming soon. And I know with the tool that we're making for local public health that gives it goes down to the block level, really fine level data for them. They're going to be able to filter it by race and ethnicity also. So they're going to be able to say, like, in this particular region, do I have a difference between who's at risk and who's being vaccinated? And is that difference even across races or not? And I think that's going to be a really helpful tool too. But I totally agree that to some degree, it's the lack of information in and of itself is a disparity.
And can I say that I think that the vaccine uptake by different groups, I think is going to be somewhat different for this virus than for, say, the flu or other things. This has been a real politicized pandemic, unfortunately. So for instance, there may be, Calumet, Michigan is probably going to have a different vaccine uptake than Washington County. But I'll shut up now.
Yeah, well, and I think for all the value in investing in mass vaccination strategies, I think we really have to understand that some of the communities we need to vaccinate the most may not respond to those strategies. And so we're going to have to be really kind of have really granular information to figure out where we need to change approaches to getting people vaccinated.
I don't know if you can see the chat now, Emily, but there's a couple of really nice comments about your presentation. Not questions, just nice comments. Thanking you for a great presentation. Are other folks on the call? We have about 5 more minutes left for any additional questions, thoughts, comments?
Happy to take more. Well, I rushed through the ending, but I didn't have a chance to thank again. I sort of tried to do it throughout, but Marissa Eisenberg and Sharon Cardia and College of Engineering and School of Information, who have been just incredible groups.
All right. Well, I'm not seeing any other questions. If anyone wants to take a minute and unmute or type a question in, we can take a couple more, or we can thank you, Emily, for a great presentation.
Thank you.
Oh, Nancy Bickel. Nardi Bickel.
The local tools for public health
Yeah.
officials. So we have a tool. It's really hard to show because nobody's going to be able to use it unless you're in the local public health official club that can get that kind of granular information. But we're actually able to map cases to the address and vaccination to the address, and then do it along age, other demographics, so that local public health officials are going to be able to look at all the neighborhoods in their county and figure out where are they having lack of vaccination and where are they having cases. And it sort of sets up all the tools that you need to start doing ring strategies. If you say, like, I have a very specific area that I want to geographically target with a unique strategy for vaccine, who are my partners in that neighborhood that we can go to? And I think it's going to be, hopefully that's going to give local public health a lot of tools for that.
Diane is asking a follow-up question. Will your tools be used by UMMG in our decisions about opening clinics?
Yeah, so I think that I think because the county will have them and Michigan Medicine and the county are beginning to really tighten their partnership on delivery, I think we can see that. I mean, this is where I think some of the power that can be, that gives the county the ability to say, this zip code needs help, and UMMG can say, okay, this is the community relationship that we have over here that we can leverage for that. Absolutely. Probability of the new peak in the next 2 to 3 months with the new variants. It's pretty, I mean, based on everything, you know, it's a race at this point. It's either, it's really this, we have to ramp up so the vaccine, we have to ramp up, the variants are going to ramp up, and it's really a matter of which hits that critical threshold first. All of the modeling data suggests that we will probably have one more peak before, at least one more peak before the vaccine really gets there. But hopefully we can hold off on letting and variant spread as long as possible. I think, you know, one of my other roles is in coordinating the genomic epidemiology efforts that we're doing on campus. And it actually is possible to contain variant spread, but it is expensive and really technologically demanding. And we just don't really have much of that infrastructure here in the United States.
Well, if you don't mind, I can give you some good news. I heard from a community partner this morning, or earlier this afternoon, who works with the Native Americans, and said that somewhat surprisingly, that they have been eager to get vaccinated. And in fact, one of the reasons for that is because the Indian Health Service has been at the front of the line for receiving vaccine, and they're so used to being at the back of the line for everything that they're appreciative of that. And so that's one of the reasons why they are eager to be vaccinated, by and large, obviously not all of them. And they're also very interested in making sure their communities, not just the Native Americans, but their communities are vaccinated. So they're using some of that supply to help to vaccinate where they are geographically. I just thought I'd share some happy news.
That is good news.
It is. Thanks, Susan. Well, thank you, Emily. Lots to think about. Really appreciate you coming and speaking today. And thanks everyone for joining. And we look forward to our next seminar. We'll have more information coming out about that. But thank you all. Take care.
Thanks for having me.